I think we'll go ahead and get started.
Yes, sir. Good evening, everyone. Welcome to Virtual Shadowing Session 87. Tonight, we have a specialty spotlight in ophthalmology, and we are joined by Dr. Preston Bloomquist. Next slide, please. This month of February, we have 3 upcoming sessions. On the 8th, we have Innovation in Medicine. On the 15th, we have a session by Dr. Fowler and Dr. Nguyen as they go over impressions at the end of admissions committee. And on the 22nd, we have a PA spotlight, which I know many of you guys have been looking forward to. And our PA spotlight is in critical care. Next slide, please. Here is our working group, which is made up of many of our undergraduate students, as well as our physician directors on the right, Dr. Fowler, Dr. Salazar, Dr. Nguyen, and Dr. Reno. Next slide, please. If you're new here, we have 2 Q&A sessions, one in the middle of our session and one at the very end. Please feel free to put your questions in chat and we'll have working group members sort through them and ask the questions from high yield to low yield. Please try not to direct message us questions as they may be overlooked. Also, before I give it to Dr. Fowler for a few announcements, I do have one last announcement myself. Every week we'll be opening a past session quiz for those of you that attend our live session, and only those who attend our live session. I know there's been a little debate as to accessing these past quizzes, but we really want to have an extra incentive for those of you who do show up on Tuesday evenings to have access to a past quiz and earn extra hours for virtual shadowing. Dr. Fowler.
Thank you, Aditya, and good evening, everybody, and welcome to Virtual Shadowing. It's so good to have you back. This for our 87th program. If you'd asked us 20 months ago that if we would be still continuing on this long, I think we would probably have said no. But the reason we keep coming back is because you keep coming back, and we're here as a service to you. It's no charge. We're doing it because we believe it's the right thing to do, and we've also seen several things, including I've just finished my 10th season on the admissions committee here, and we definitely saw many, many students putting virtual online shadowing hours on their applications. And I can see definitely that we're paying attention to online shadowing hours. And indeed, as we would be looking at a student, we would say he has 200 shadowing hours, of which 120 have been virtual online and the other 80 have been in person. And so I think that we're performing a service that's going to be helpful for you as you apply for your healthcare career. So if you keep coming back, we're going to be here. Tonight's presentation is outstanding. One of my really close friends and someone I deeply adore, and someone with whom I spent years on the admissions committee here at UT Southwestern. And so we will get into that a little bit presently, but I think you're going to just love this presentation tonight. We're glad you're here. We're going to keep being here if you keep coming back. And so, Aditya, you want to introduce our guest?
Yes, sir. Without further ado, it's my pleasure to introduce Dr. Preston Bloomquist as he shares what a career in ophthalmology entails, a few interesting surgery cases with videos, and the steps involved in pursuing his profession. Dr. Bloomquist, please take it away.
Well, thank you very much. I wasn't quite sure I was signing up for, but I know you never say no to Dr. Fowler. So hopefully this will be of interest. He asked me to talk about how I got into medicine and ophthalmology. So I guess I'll start by just saying I come from Austin, Texas. I'm a 5th generation Austinite. I come from a family of engineers. All my family are engineers. My father was a civil engineer. My grandfather was a civil engineer. They both worked for the state highway department here in Texas. My uncle was a chemical engineer. They all went to the University of Texas at Austin. So I bleed orange blood. But as a first grader, I wanted to be a paleontologist. Dinosaur bones, that was where the action was for me. We all, as kids those days, had models of a Triceratops and a Stegosaurus way before Jurassic Park. But then I read a book that talked about paleontology, and it mentioned that paleontologists spend long, long hours in the hot sun with very little pay. And I thought maybe that's not the career that I want. So As a second grader, I switched my interest to wanting to be an astronaut. And that's just right around the Apollo program. I started really getting into aeronautics with Apollo 7. Wally Schirra was my favorite astronaut. My father was in the Air Force as a master mechanic fixing planes. So I had models that I was building planes and jets and fighters, and then progressed to the Saturn V rocket and the lunar excursion module, the service module, the command module for the Apollo program. I just knew that was where I was going to end up. But then I had my first encounter with ophthalmology. In second grade, I failed my school vision exam. I went to the ophthalmologist with my mother. They put a big E on the board 20 feet away. And my ophthalmologist said, "What do you see?" And I said, "I see a Bible verse." And they looked at me and said, "What are you talking about?" So, there's a big letter kind of on one side, like those illuminated manuscripts have, and then there's a whole bunch of lines. So I was pretty sure that's what it was. And he said, "Well, walk up until you can see what it is." We got about 5 feet away from the letter. Said, "Oh, it's an E." And so that shocked my parents. I got my first pair of glasses, and I could actually see leaves on the trees and see the blackboard. And I remember my mother saying, "How did you get through school if you couldn't see the blackboard?" And I said, "Well, the teacher, she said everything she was writing, so I knew what I was supposed to do." But that really changed my life. This simple pair of glasses made a huge impact for the rest of my life. Whereas other doctors I went to, the family practitioner, he kept jabbing me with needles all the time. Went to dermatologists for my acne, giving me these creams and phototherapy, and that never seemed to work. But my ophthalmologist had the most impact on my quality of life. I had my second encounter with ophthalmology in middle school. My mother developed a subfoveal idiopathic choroidal neovascular membrane. That's a lot of words, but it basically means that blood vessels were underneath the retina in one of her eyes, and we don't know why. It just happened. And it causes a loss of vision. So there's a distortion of the central vision. She wasn't able to see well that eye. And back at that time, there was this new experimental treatment with an argon laser that was not in Austin, but they had one in San Antonio. So she went down to San Antonio for this treatment where they're going to take the laser and destroy those blood vessels. And it worked, except because the blood vessels right underneath the center of the vision, it also completely destroyed the center of her vision. And she came back, it was 20/40 before that, and she came back after that treatment. She's 2400 immediately. So legally blind in that eye. And I got to see far closer than I really wanted to what vision loss does to a person. Here's somebody who, my mother, she used to drive race cars, rally cars when she was younger. And now she felt, she lost her depth perception. She lost central vision in one eye and took that extremely hard. And for many weeks, she was quite upset about this sudden loss of vision. And I was thinking, well, you have another eye. You see just fine out of that eye. In fact, I tell my patients who have one eye, there is an importance for depth perception when you're hunting the woolly mammoth, right? When we're cavemen, we have to have good depth perception to throw that spear to kill that woolly mammoth so we can eat that night. But you only need one eye to grab a can of beans off the grocery store shelf. So in this day and age, depth perception, you can still do pretty much anything. You can't be a microsurgeon, you can't fly, can't be a pilot, but anything else you could pretty much do. But there's always that fear once you lose one eye. What happens if the other eye happens? This happens to the other eye. What happens if I have a trauma and I lose everything? I go blind. So that fear of vision loss was really ingrained in me when I saw how upset my mom was. Unfortunately, her other eye's been fine all the rest of her life, but it was extremely traumatizing for her. So I went through school and, I was pretty smart, could take a test pretty well. And my junior year of high school, I had a science elective I could take. So I took physiology and I really loved it. So when it came time to decide what I was going to do with my life, I told my family, instead of being an engineer, I was going to be a doctor. Well, that's fine, son. That's okay. I'm still going to go to UT Austin. Well, that's good. In fact, UT Austin was the only school I applied to for college. And I'm going to go major in biochemistry. And my parents said, whoa, no, that's going too far. So what do you mean? I think biochemistry would be an excellent preparation to be a doctor. So no, you're going to be an engineer. to be an engineering major. So why am I going to be an engineering major? Well, if you don't get into medical school, you'll have a career. So that was the philosophy. And I said, no, I'm not going to do that. And I rebelled a little bit, but my parents, my father set me up with the dean of engineering at UT Austin, and he talked to me. And in fact, he said, well, you know, you're an ophthalmologist. He's on faculty here in the dean in the College of Engineering. He not only practices ophthalmology, but he actually teaches at the school. He was an engineering major before he went to medical school. You could do that. I went, well, yeah, but you know, to me, biochemistry seemed like a better fit. Then he finally said, well, you know, what are your grades? What's your SAT score? Well, you know what? We got some scholarship money. You know, the engineering school is pretty rich compared to natural sciences. So we've got some scholarship money for you. So that's great. I'm an engineer. So that's how I became an engineering major. But I had my third major encounter with ophthalmology my senior year of engineering. My engineering mentor told me when I started, skip Intro to Engineering 101. Because at that time, it was all about calculators. There were Texas Instrument calculators, and there were Hewlett-Packard calculators. And to use a Hewlett-Packard calculator at that point, you had to know reverse Polish notation. So it took you several months, I guess, on this course to learn how to do that. So he said, just skip that. That's simple stuff. When you come up your senior year, nobody's going to make you go back and take Intro to Engineering. So I said, okay, that's fine. And sure enough, came up my senior year and said, oh, I forgot to take Intro to Engineering 101. Not a problem. Take something else. I said, that's great. I'm taking biochemistry. I don't know why I thought in my mind I had to take biochemistry, but that's been with me. So the engineering folks said, no, you can't do that. I said, what do you mean I can't do that? Well, it has to be an engineering course. You skipped an engineering course, you have to take an engineering course. And I'd taken all the engineering courses that really appealed to me. Most of my courses were electrical engineering, but I had some chemical engineering courses, some mechanical engineering courses. But I found a graduate course that really appealed to me at that point called Electrophysiology of the Nervous System. And it was taught by my ophthalmologist, the same person who put me in glasses way back in second grade. And it was essentially neuro-ophthalmology. The entire graduate course was teaching neuro-ophthalmology. And that was just fascinating to me. So I entered medical school somewhat leaning toward ophthalmology, as you might consider, and hit the gross anatomy labs, and it wasn't too exciting for me to go cut through those muscles in the arms and the legs and find those internal organs. But we got to the eye, and that was kind of fun. I kind of liked dissecting the eye and seeing what was in there. And then the lectures I got from the ophthalmologist during the second year of medical school were really appealing to me. The ocular pathology, red eye, uveitis, trauma. I love that. Started my clinical rotations, and I started on obstetrics. Loved obstetrics, catching those babies, suturing up those episiotomies. It was wonderful learning how to suture early on. I really enjoyed using my hands to do that. Then I hit gynecology the next month. Hated gynecology. Knew that wasn't going to be for me. Did medicine, and at UT Southwestern, medicine is a primo specialty. That's what built the reputation of UT Southwestern in its early days. And I really love the diagnostics of medicine, trying to figure out this puzzle of what's happening to this patient, looking at the physical examination, looking at the labs, and trying to put the picture together. So I really love that. Then I hit surgery, and I liked sewing up, suturing and sizing things and sewing it up, but wasn't real thrilled with dealing with the abdomen, and I remember sitting there, long cases, standing up, hands in the abdomen, and then the resident would perf the bowel. He would slice the bowel, and the smell was just overpowering. It's like the worst fart you've ever smelled. I thought, that's not the kind of practice that I want to have. If I couldn't be an ophthalmologist, I probably would have done family practice, because at that point, family practitioners, they only saw people in the clinic, but they could assist at surgery, they could deliver babies, and you really can't do that now as a family practitioner. So the next best thing was being an ophthalmologist, because I got to do everything as an ophthalmologist. I got to do the medical side of eye care. I got to do tertiary care, secondary care, as well as primary care. And better yet, I could be a surgeon after only 4 years of postgraduate training, where I was seeing my colleagues going into surgery. They were taking 5, 7 years before they get out and cut on people. So I was really enthralled by the idea of being an ophthalmologist. So with that, let me just talk a little bit about ophthalmology itself. The earliest written reference to cataract surgery goes back to the 5th century BCE. If you look at the Sanskrit texts, they talk about trying to remove the cloudiness from eyes. The first subspecialty society in America was actually the American Ophthalmological Society back in 1864. In the middle of the Civil War, we're founding the first subspecialty medical society in the United States. We are a very technical oriented specialty. We were the first specialty to incorporate lasers into everyday practice. So it really appeals to my geek side. When you talk about the type of practice we have, most ophthalmologists, we practice a mix of medicine and surgery, which is what I really like. I like both of those types of practice. The average American ophthalmologist, we spend 4 days a week in the office, and then about 1 day every week in the operating room. And the most commonly performed ophthalmic surgical operation is cataract extraction. If you look at the most common clinic procedure that we do in our office, it's going to be intravitreal injections. We're actually taking medication and injecting it directly into the vitreous cavity. So if you're going to be an ophthalmologist, you've got to have good fine motor skills. You can't be all thumbs. You have to be able to be facile with your fingers, because you're going to be doing a lot of very precise movements in very small spaces. And unfortunately, you have to have good depth perception. I see a lot of medical students who come and they are so thankful their ophthalmologist has maybe treated a retinoblastoma in their eye and saved their life when they were young. And they have poor vision in one eye and good vision in the other. Or they've had strabismus, where the eyes were crossed in or crossed out when they were young. And their pediatric ophthalmologist got them straight so they looked normal and really improved their social standing and improved their vision. Or they treated their lazy eye and got that much better. But they don't have good depth perception. And unfortunately, to be an ophthalmologist, you have to have 2 eyes that function well together. The instruments that we use, the monocular indirect ophthalmoscope to look in the back of the eye, it's right there in the name, binocular. You have to have 2 eyes to be able to function. And people will sit there and say, well, but I know surgeons who only have 1 eye. Well, it's a little different if you had 2 eyes when trained and you have 1 eye now, you lost one to trauma or disease. And even then, you've lost some of your surgical capability. You're not going to be, there's a glass ceiling. You're not going to be able to be that exceptional surgeon you used to be. You've lost some of your ability to discriminate the different tissues. And so it's important, if you're thinking about ophthalmology, to make sure you can function with both eyes. My wife was in the upper echelon of her medical school class. And she thought, well, you know, ophthalmology is competitive. I'm really smart. I need to check that out too. That sounds like a really good thing. So she went and assisted on several eye surgeries. And the first thing she realized was when she looks in an operating microscope, she gets headaches. And quickly realized that's not what I want to do with my life, having to take something to cure my headache after every procedure. So instead, she went to do pediatrics and then went on to do her fellowship in allergy and immunology, where she was very successful. So it's important to make sure you have that capability to spend a long time under the operating microscope. Nowadays, we have virtual simulators. And so here at our medical school, we have an IC virtual simulator where you can actually do, as a medical student, parts of the cataract surgery or retina surgery, very good simulation where you can go under there without harming any patients and learn how to manipulate your instruments in a closed space. We put our residents, before they do intraocular surgery on live patients, through a complete module on the IC virtual simulator. So hopefully, when you go to medical school, if you're interested in ophthalmology, have them put you on the IC and do some modules to make sure it's like playing a video game. It's wonderful. And if you enjoy that, that's fantastic. Color vision is also important. Stereopsis, there's some good data that you have to have good depth perception to be a good ophthalmologist. Color vision, a little less data, but we have had people, when I've talked to other program directors who say, what am I going to do with this person? He has red-green color blindness and he can't discriminate between normal retina and diseased retina. And that's a problem. So if you have a real bad color vision problem, then you probably can't be an ophthalmologist. You really have to have good vision, unfortunately, to be able to be in this vision critical field. And I tell medical students, if you can't be an ophthalmologist, that's fine. When you're a medical student, you're a part of an exceptional group of people. Our medical students, to a T, they bring something new, something exceptional to training. You want to find a field where you can excel. You don't want to just be competent. That's not the goal when I try to train an ophthalmic surgeon, train a resident. I don't want a competent surgeon. I want an exceptional surgeon. I want an exceptional ophthalmologist. So you want to find a field that you can really excel at, that you're going to enjoy for the rest of your life. So with that said, ophthalmologists, we're in demand. Baby boomers like me, we're starting to retire. And there are a lot of diseases that affect the aging population, and we're living a lot longer. We want to be able to play pickleball for the rest of our days. And that means we got to see that ball come at us quickly and react quickly. So we want to be able to see fantastic. And why be an ophthalmologist? It is just way cool. What I do is fun. At least I think it's fun. And that's something I hope that whatever you decide to do, find something you think is way cool as well. So I'm a comprehensive ophthalmologist. What that means is I see all patient ages from cradle to grave, from birth to death. I'm going to perform examinations for eye health, for disease. I'm going to do consults for systemic diseases. There are many diseases, systemic diseases that cause eye findings. And sometimes I will make the systemic diagnosis before the primary care physician because I can see the patterns in the eye and say, this person has this inherited disease, or this person has the diabetes. Why don't we check him for a hemoglobin A1C, what his blood sugar is, and I bet you dollars to donuts that it's going to be elevated. We also monitor for adverse drug effects. Many of the medications used to treat other diseases will cause damage to the eyes. And so we have to monitor for those situations and try to make sure we prevent damage, stop medications for other treatments, or adjust to different medications if it's affecting the eyes inappropriately. And we correct refractive errors. And again, I'd tell you the most impact you may have on a patient is a simple prescribing of glasses. Being able to give somebody clear sight is the most rewarding thing you can do. People have such a connection, such a fear of vision loss, such a connection in our field. Think about what we do day in, day out. You can't drive without sight. You can't look at your cell phone without sight. We are very much a sight-dependent society. So be able to keep people with good vision where they can function productively in society is a huge plus. Whether that be through spectacles, which again is the safest, most reliable way to correct vision. I kept telling people, if spectacles were invented tomorrow, the advertising would be no longer you need to put a piece of plastic in your eye or have surgery to see. And there would be lines around these glasses stores like you see around the Apple store when a new iPhone comes out. Unfortunately, people want to go to the latest, greatest thing. Oh, I'm with surgery, so I don't have to wear glasses at all. Glasses are a fashion statement. Everybody should wear glasses. For another reason, to protect you from the outside environment. So when that pickleball does come at your eye, it's not hitting your eye and smashing it. It's you've got the protection from your glasses. So what else do I do? Well, I perform laser surgeries. So a comprehensive ophthalmologist can perform keratofractive surgery. We can change the shape of the eye so you don't need to wear glasses. After cataract surgery, sometimes the membrane behind the lens implant will get cloudy, so we can use a laser to open up that membrane and still have that lens implant stay in place. Whereas in the old days, we didn't have to take a knife to incise through that membrane. We can do it with a YAG laser in this day and age. Glaucoma lasers, so I can treat high pressures in the eye by using a laser to increase the outflow of fluid from the eye. And retinal photocoagulation, where I can treat abnormal blood vessels, tumors, things like that. And we perform a wide variety of surgical procedures in the operating room. Again, cataract extraction with intraocular lens implantation is kind of bread and butter surgery for the comprehensive ophthalmologist. And it used to be you took out the cataract, you give patients glasses. And nowadays, I can take out the cataract and change the refraction of the eye, refractive state of the eye, by putting a special lens implant in that will correct your astigmatism that you have in the cornea, or make it so that you are perfect without glasses. And now newer technologies allow you to see not only a distance, but the monofocal lens is what you can see. But now with these multifocal lenses or extended depth of vision lenses, you can see not only a distance, also into intermediate and even sometimes near. So you may not need to wear glasses whatsoever after your cataract surgery. Corneal surgeries. So pterygia, very common near the equator. You'll get a growth over the cornea. We take those off all the time. Glaucoma surgery, filtering surgery, oculoplastic surgery. So we'll perform surgeries around the lid or take tumors off in the anterior orbit. And then strabismus surgery, where the eyes are crossed in or crossed out or not quite aligned. We can move the muscles, the extraocular muscles on the sclera to a different position so that the eyes will be more aligned and look straight ahead and improve the vision for patients. So there's a lot a comprehensive ophthalmologist can do. Now you would think that should be enough then. You know, you're doing everything in this, you only have these two little eyes, these two little orbits. That's not a lot of space. But actually, there are about 9 or 10 subspecialties of ophthalmology. You can go in after your 4 years of training and do an additional 1 or 2 years of training to be a further expert in ophthalmology. You can specialize just in the cornea and the anterior segment. Those are the people who do corneal transplants. And used to be we had to transplant the entire cornea. Now we can transplant just a certain layer if we need to. So if you have a corneal edema because your endothelium of the cornea is not working, we can just transplant that endothelial layer with its Descemet's membrane, its basement membrane, into the eye and decrease the risk of rejection, have faster healing time. Glaucoma, people who just take care of people with high pressure in the eye. So glaucoma is kind of analogous to high blood pressure. So we're talking about high eye pressure, and that high eye pressure can damage the optic nerve and cause vision loss. Vitreoretinal disease, so diseases of the vitreous in the retina. There are retinal surgeons, that's all they do is work on the back part of the eye where the photoreceptors are, trying to repair retinal detachments, try to treat people with diabetic retinopathy. Pediatric ophthalmology, all right? These are the people who take care of kids with inherited problems or with strabismus. They take care of not only kids, but also adults with crossed in or crossed out eyes. Ophthalmic plastic surgery, all right? Taking care of people with lid problems, with orbital tumors. So if you like blood, you can get into blood in ophthalmology by going and doing those orbital surgeries that can be quite impressive, fixing orbital fractures. Neuro-ophthalmology, looking not only at how the eye works, but all the connections all the way back to the occipital lobe and the association areas that put sight together. Ocular inflammation, that's taken care of by people who have specialized training in ocular immunology and uveitis. Ocular oncology, primary and secondary tumors of the eye. And finally, ophthalmic pathology, there's such strange disease that you see only in the eye that there's a whole subspecialty of pathology that deals just with the diseases, the pathology of the eye. So there's a lot of things you can do in ophthalmology when you even further specialize. So really, if you're going to be an ophthalmologist, you need a lot of different skills. So maybe part microsurgeon. So you have to be able to do surgery under the operating microscope. Again, that eye is not very big. We're talking 24.5 millimeters long. This hollow organ that we're working in very tight spaces, try not to ding up these very fragile tissues in the eye to help restore sight. You've got to be a plastic surgeon, all right? You're going, well, but plastic surgeons, they can work on lids and do some of this stuff. The ophthalmic plastic surgeons, because they're ophthalmologists first, our first concern is to make sure the function of the eye that's always preserved. So we don't want people with wide eye stares, all right, after their blepharoplasties, because then they can't blink and refresh their tear film, and that degrades their vision. So we take a lot of care when we take off this excess skin to make sure that their eyes can still close, they can still function, they can still see. I tell my patient, I'm not going to make you 20 years old, look like you're 20 years old. I'll take 20 years off your face, but we want to make sure, number one, that your eyes function perfectly. And there's a lot of function with that lid that's important. And these are the guys also that are doing orbital tumors and things like that. That'd be trauma surgery, all right? We see, especially at Parkland, lots of trauma coming in where kids, adults will have, get something in their eye, beer bottle is broken or glass gets broken and cuts their eye, or somebody takes a knife and knifes an eye, or you see somebody shot in the eye, or you see somebody hit so hard that the eye just explodes. And our goal is to put that eye back together, make it round, make it watertight again, prepare it for further reconstructive surgeries so that we can preserve vision. And we've been very successful now over the years as our techniques have gotten better, our sutures have gotten smaller, our understanding of the inflammatory process has gotten better to be able to restore sight in eyes that who would have thought we could ever get any vision out of. You get to be a diagnostician. The very first episode of House that I watched happened to be episode 6, the Socratic Method, where a woman presented with jaundice and neurologic symptoms, and the diagnosis of Wilson's disease was made by a slit lamp microscopic examination. So taking the patient to the slit lamp and looking at this ring, this Kaiser-Fleischer ring. You can see it right here. It's a deposition of copper in the posterior portion of the cornea and in the periphery. And this is almost diagnostic of this inability to excrete copper into the bile, Wilson's disease, which causes these symptoms. You can make this diagnosis as an ophthalmologist and solve a lot of problems. Another patient down here below with this verticillate keratopathy. You see this vortex type of dystrophy in the cornea, this deposition of, in this case, Fabry's disease, which is a lysosomal storage disorder, but you also see it in amiodarone use. So people on this cardiac antiarrhythmic medication, 100% of the time, will get this similar type of appearance of vorticillate keratopathy. So a lot of things you can see in the eye that will help you make systemic diagnoses. You have to be a pediatrician. Again, we see all ages. So you have to be able to work with kids, learn how to patch kids, force them to use a lazy eye, whether it's through patching or through other medicinal ways to blur the vision of the good eye, to force them to use that other eye, or to straighten their eyes, as you see down below. And working with kids, that's sometimes like working as a veterinarian. They're not telling you what's going on, or working, think of it as working among cavemen who don't have the verbal skills to tell you what's going on. You know something's going on. They're trying to tell you, but all you hear these grunts and whoops and da. So you know something's wrong, you got to figure it out. Geriatricians, that's the opposite end of the spectrum, where you have to figure out what's going on to somebody who, again, may not have the vocabulary to understand what's going on with their eyes. Oftentimes we'll see people sit there and say, I can't see it out of my right eye. And what they really mean to say is, I can't see to the right side, because both eyes see the entire visual field. If you can't see the right side, that means you have a stroke, perhaps, as opposed to not being able to see out of one eye. So you have to be able to figure that out, and you have to be able to talk to somebody who has a lot of history and can tell you a lot of things about what's going on. And there's a lot of diseases that are peculiar to the aging eye. You get to be a neurologist, all right? We think about, oh, it's just the eyes. Well, it's more than just the eyes. The eyes are connected through the optic nerve, through this peculiar decussation of part of the fibers to the contralateral side, but the visual radiations go back to the occipital lobe, where your brain puts together sight, but then you need to interpret that. And so the association areas anterior to the occipital lobe have to go back and see what is going on. What am I actually seeing? And put a name to that. That's a horse. That's a horse running. It's this color. It's our brown color, whatever. And anything that disrupts those pathways from the eye all the way back to the back of the brain, that's going to affect vision and movements of the eye. So things that occur in the brainstem and the nuclei of the third, fourth, sixth cranial nerves, that's going to cause movement disorders. So you have to be able to put all that together and predict where the lesion is, find out where the lesion is, and then find out how you're going to treat that. But to be a psychiatrist, I talked already about my mother's experience and the devastating loss she felt after losing vision in one eye. When I see people that I've repaired or come in with horrible trauma in one eye, you have to first prep them for surgery and let them know I'm going to do everything I can to try to save this eye, but I may not be able to. And when I get into surgery, I will do my damnedest to put that eye back together, no matter how badly damaged it is, because there's only one thing worse than waking up blind after surgery. It's waking up blind without an eye. So if they wake up, they have their eye there, they understand, the surgeon did everything they could to try to give vision back, and the eye was so badly damaged, they're much better off psychologically taking the next step. So it's a badly damaged eye. It's going to give you problems. We need to take the eye out to prevent damage to the other eye. Unfortunately, that's pretty rare, but about 1 in 500 cases, you actually get vision loss to the second eye, to the good eye, from the badly damaged first eye, what we call sympathetic ophthalmia. And there's things called like functional vision loss or non-organic vision loss, where people just don't see. So hysterical blindness, for example. And after the first Gulf War, we saw an increase in kids coming in complaining that they couldn't see. There was nothing wrong with the eyes, but what was happening? They were sitting with their parents watching war in the Middle East every night at 5 o'clock on the news. One of the first, real-time wars with CNN being broadcast, and people didn't realize what an effect this had on kids who were thinking, could this happen to me? Is this war going to happen to me the next day here in my hometown? So you have to go and figure out, make that diagnosis, and then figure out how are you going to treat that individual so you can reassure them and have their vision come back. Or you'll see patients who are malingering, who are faking their blindness for secondary gain. You have to figure that out as well. Sometimes you got to be a fashion consultant. You have to tell Cameron Diaz here in the bottom left that there are very few indications for tinted lenses medically, but if you want to wear rose-colored glasses, that's fine. Harry Carey, I don't know if you're probably too young to know who Harry Carey was. He was an announcer for the Chicago Cubs. You can see Will Ferrell's impressions of him on Saturday Night Live. You go to YouTube. He has these huge, huge glasses. Now, if you're as nearsighted as I am, the bigger the frames you have, the thicker the glasses are going to be on the edge, and the heavier those lenses are going to be. And I've seen people come with these huge glasses. They're complaining about, my glasses are so heavy, I just hate them. Yes, you need glasses that are smaller, like America Ferrara's glasses here on the right. So sometimes you have to guide them, give them a little push to get glasses that will fit their psyche as well as make them more comfortable. Usually your optician will do that, and hopefully you'll get a good optician. There's really an art to fitting glasses on a face. I feel oftentimes I'm a docent in a museum. Looking in the back of the eye is humbling, and it's beautiful to look back. The retina is the only place in the body you can directly observe the microvasculature in vivo. You can see the damage that hypertension causes. You can see the damage of diabetes. You can't see that anywhere else unless you cut open a kidney and put it under a microscope. Here, I can peer in and see damage, see health, hopefully most of the time. Here in the lower left, you have a patient with a vasculitis, and up here, you can see these sclerosed blood vessels and some intraocular hemorrhage, some hemorrhage in the retina. Or you'll see patterns that you can recognize and make a diagnosis visually. So here in the upper right, you see what we call this characteristic cottage cheese and ketchup appearance of cytomegalovirus retinitis, very common in patients who are immunosuppressed, either with HIV or after, say, solid organ transplantation on powerful immunosuppressive medicines. Or down here on the lower right, this patient with this white ischemic retina, characteristic of a branch retinal artery occlusion. So it's really amazing to be able to peer into somebody's body and see the effects of disease on the microvasculature, or be able to see a pattern and say, I know what that is. Here's my diagnosis. You can also let your inner geek fly. When we talk about ophthalmology, what I love about it, there's a lot of physics, there's optics involved. Everything can be measured, quantified. You now have superior imaging modalities where we can see all the layers of the retina. That wasn't around when I was going through my training, but now I can image the retinal layers. I can image them coronally, I can image them sagittally, however way you want to cut it. I can look at each layer of the retina and look at its individual vasculature. I can look at the cornea, the shape of the cornea, the thickness of the cornea, and be able to diagnose disease from that, or figure out how do I want to change the shape of the cornea so that a patient doesn't have to wear glasses down the road. What I really loved was I could precisely measure my surgical outcomes. If I'm, if I do a cholecystectomy, take out a gallbladder, my outcome is going to be, is it healing? How's the patient feel? No, it hurt a little bit. It's still hurting today, blah, blah. For me, I know what my visual acuity is postoperatively. I know what my postoperative refraction is. I'm doing glaucoma surgery. I can measure the intraocular pressure and see it come down and make sure it comes down. I can measure that over time and see what happens when the effect wears off, if I need to retreat. I knew exactly how well I was performing to benchmark. And I like that quantifiable nature of ophthalmology. So it kept pushing me to get better and better and to try to get better results for my patients. And it just makes you feel wonderful when the patient comes in the next day and you take off their patch and they're seeing the 2020 line, the 2015 line. And, that's just a nice feeling to be able to do that. And you get to be a sharpshooter. So you get to take my laser out and fire it in the back of the eye or at the front of the eye to change the shape of things, or drill holes in the iris to correct angle closure glaucoma. So I can let my Captain Kirk fly as well. And finally, you're going to be a teacher. Whether no matter what you do in medicine, you're going to have to teach, whether it's your patients or your peers or students, medical students, residents, fellows. You have to be able to teach no matter what you do. So I'll finish the story of my journey in medicine. I finished my ophthalmology training. I was well prepared to be an ophthalmologist. And I wanted to go back and open a solo practice in my hometown of Austin, but I knew better. I was not trained to run a practice. I knew I lacked the business skills to do that successfully. So I joined a multi-specialty group here in Dallas, the Permanente Medical Association of Texas. And I thought, I'll practice comprehensive ophthalmology. I loved it because I could do as much as I wanted. I could refer out the patients who needed subspecialty care to the medical school here in town. And those are the people that I respected. I thought I'd be doing that. And, maybe a couple of decades from then, I might be chief of the eye service department. Well, I was chief of eye services after 3 years. And 2 years after that, I was in senior management as the head of organizational performance and improvement, which basically I oversaw all the quality improvement, the risk management, and the utilization management aspects for the health plan. And the Permanente Medical Association of Texas was a closed model health maintenance organization plan, and excellent results, excellent outcomes. But it was clear in our modeling financially that it was not going to fly in Texas. Very popular, this Kaiser Permanente model, very popular in California, where it's been there since World War II. But Texans want choice, including the choice to make bad decisions, whether it's about their health care or their elected officials. We Texans want choice. So we kept telling the organization that we wanted to open up to more fee for service in addition to the closed model. We were told, no, that's not going to happen because it works well in California, and could not convince them that that was the way we needed to go. And I got tired of fighting that battle. I got tired of talking to employer groups about our quality of care or to our internists about improving cardiac care, because I really wanted to be an ophthalmologist. That's what made me excited. So after being with the group for 8 years, I told them I wanted to go back. Instead of just practicing half-time ophthalmology and doing half-time senior management, I wanted to go back to full-time ophthalmology. I did that, and the second month I was back, I saw an ad in our major journal, the Blue Journal, Ophthalmology, for the chief of ophthalmology services position at Parkland Health and Hospital Systems, and joining the faculty here at UT Southwestern. And I'd always been a volunteer faculty member all through my time in private practice. I'd spend a half day each month staffing the residents in cataract surgery at Parkland. And that's, quite frankly, when I had the most fun with my profession. So I thought, well, let's try that. That might be kind of fun for a while and see how that goes. And here, over 23 years later, I'm still here teaching residents and enjoying myself. And my hair has gotten a little grayer because of when you deal with residents, that tends to be the first thing that happens is your hair goes gray. But I really enjoyed being an educator as well as taking care of my own patients here at UT Southwestern.
You know, Preston, God, what a great talk this is. Firstly, we've already had many questions and comments, and including a lot of folks being very honest, you know, about having trouble getting used to wearing glasses and so forth. And one young lady just spoke up about, you know, your words have really helped her get used to wearing glasses. And I remember there was an advice to the Love Lauren column called Dear Abby. You'll remember that. And this gal writes in and she says, Dear Abby, I've found that I'm going to have to wear glasses. And I'm so sad because I'm afraid that means that men won't ever look at me. And Dear Abby says, dear whatever, worried in Indiana, please don't worry about that. Just remember, guys love dames with the good looking frames. What a great talk. Preston, we've had dozens of people already write in just saying, gosh, your passion for this is just marvelous. So I just wanted to share that with you.
Well, I appreciate that.
So reality check.
So yeah, first, make sure you can spell ophthalmology. You'll be surprised how many people I see on their application have misspelled ophthalmology. Get all the H's in there, get the O's in the right place. It's bad form if you can't spell ophthalmology. And in fact, when I came to Parkland, ophthalmology was misspelled on the signs to the ophthalmology clinic, both in English and in Spanish. It took me 10 years to get ophthalmology spelled correctly on the signage at Parkland in English, and it never got spelled right in Spanish. I still have sweaters and T-shirts with ophthalmology misspelled on it from Parkland.
That's hysterical.
We moved just recently to the Moody Outpatient Clinic, our brand new eye clinic I was able to design for our residents with 36 eye lanes for our residents to see patients in. And the first thing they said was, well, what do you want the signage to say? I said, oh, that's easy. Eye clinic. Everybody knows what an eye clinic is. Nobody knows what ophthalmology is in our population. No eye clinic or Clínica de Ojo. All right. So that is spelled correctly. So we finally have gotten that spelled correctly. So eye clinic, in fact, there was a push many years ago to differentiate ophthalmologists from optometrists. And we called ourselves IMDs, EYE-MDs, which is what we are. The good news, and if you're a U.S. senior, 80% of U.S. seniors get in. So it is a difficult, competitive specialty, but it's very doable. If you're in the top half of the class, you're probably going to match into ophthalmology. If you're in the bottom half of the class, you better have some other characteristics that really make you valuable, a PhD or some outstanding research, some real experience that makes you valuable, but to a residency program. But grades matter, unfortunately. So beware of that.
Hey, Preston, by the way, you've got 360 kids from around the world sitting on the edges of their chairs right now. No pressure, but you got a lot of people loving this talk tonight.
Well, good. I'm glad. So it's a 4-year residency in the United States. We just had the first change in education for ophthalmology. It used to be that you did a separate internship in something, a transitional internship, a surgical internship, medical internship, and then you started 3 years of ophthalmology residency. We have just now changed throughout our teaching nationwide to a 4-year residency program where the internship year consists of 9 months of non-ophthalmology direct patient care. We're very fortunate. We have an integrated internship here at UP Southwestern. We put our interns through 4 months of inpatient wards and internal medicine. They get a month of rheumatology because a lot of rheumatologic disease has eye findings. A month of endocrinology because we want them to know how to manage diabetes and thyroid eye disease and things like that. They do a month with Dr. Fowler in the surgical emergency department, a month on neurology, because again, the eye is connected to the brain, or what we like to say, the brain is connected to the eye. And then a month in otolaryngology, because the sinuses are right sitting up there by the eye. So we have a lot of times where sinus disease can cause issues and head and neck disease can cause issues with the eye. And then they do their next 3 years.
Yeah, Preston, is it a phenomenon that every specialist thinks that the organ that they're specialized in rules the body? The kidney doctor says the entire body is made to support the kidneys. Go ahead.
And ophthalmology is an early match in the United States. So unlike every other specialty, which is going through the National Resident Matching Program, we actually go about a month and a half earlier for our match through a separate program, the San Francisco Matching Program, which was built by the ophthalmology specialty programs. So with that, we can pause for a few moments and we take a few questions before I get into the cases.
Sounds good. We'll go through about 3 or 4 questions and keep moving. But first off, where do you think ophthalmology is heading in terms of technology, growth, demand, and etc.? And how should prospective ophthalmologists prepare for these changes?
Wow. So one of the things I'm really excited about with the integrated internship is it gives that broad spectrum of training. One of the things I'm very disappointed in people applying to ophthalmology, we see a tendency in that 4th year of medical school to do ophthalmology rotation after ophthalmology rotation after ophthalmology rotation. Don't do that. You want to take that time to do something different. Dermatology is going to help you tremendously in ophthalmology because most skin cancers around the eyes, basal cell carcinoma, varices, sebaceous cell carcinoma, squamous cell carcinoma, that's going to be important. Otolaryngology, dermatology, radiology, so you can read those films, pathology, so you know what you're doing when you get the pathology report, and you can go see the slides and make that diagnosis. There's sometimes we have to go down there and collaborate with the pathologist and say, what kind of tissue do we need? I think it's going to be this type of tumor, but what type of tissue do you need? It frozen? Do you need it? Can be in formalin. There's some tissue you have to have fresh tissue in to stain with oil red O to make sure you make the diagnosis correctly. So anything you do, that broad spectrum of medical school training is what you want. We try to discourage people from doing a lot of away rotations and different ophthalmology rotations. You're going to get that in residency. Medical school, internship, that's the time to get a broad training. So I don't know where ophthalmology is going. We're going to see more genetic therapy. In fact, the first approved genetic therapy has been for Leber's congenital amaurosis, a congenital blinding disease, where we can actually now insert with an adenoviral vector a gene product into the eye that gets into the retina and restores sight to people who are blind, who are born blind. It's incredible. That's where we're heading. We're going to see more microsurgery. glaucoma is a field that is burgeoning right now. I've got half of my current class thinking about doing glaucomas, especially because now we have multiple minimally invasive glaucoma surgeries that actually work, as opposed to some of these very brutal surgeries we've had in the past to create a new pathway for fluid to exit the eye. We're having more understanding of what glaucoma is and how we can treat that surgically without the brutality we've had in the past. We're seeing mathematical modeling of the aesthetics of the eyes. The oculoplastic surgeons, one of our faculty members is mathematically modeling what is the ideal blepharoplastic wound supposed to look like, and how do we improve the aesthetics of people who have had trauma to the eye or tumors in the eye. We have a major advance. There are diseases that I was training with, we had no cure. The treatment, for example, of macular degeneration was, I'm sorry, you've got this big scar in the back of the eye. There's nothing I can do. Let me send you to a low vision specialist. They can teach you to live with it. We now have medicine, these anti-vascular endothelial growth factor products that were developed for cancer. Their anti-angiogenic properties, I can stick in an eye and reverse vision loss for the very first time in people with macular degeneration. If this had been around, my mother would still be able to see with her one eye. Tremendous development. So ophthalmology, we've had this this cachet of being the first in many things, the first in genetic therapy, the first in routine use of lasers. I see that's going to happen and continue to happen. The next frontier is presbyopia. Everybody gets presbyopia as they get over 40. Presbyopia is Greek for old man's eye. That's when your arm isn't long enough to see. You have to play trombone to see things up close. That's the next frontier. Can we make it so that you are able to see at near without glasses for the rest of your life? And then finally, how do we get rid of cataracts that don't develop in the first place? There have been some interesting projects, one with dogs, feeding them a sterile type of medication that actually reverses age-related nuclear sclerosis. So maybe at some point, we won't even have to talk about cataract surgery. We'll be giving you a pill every day, every week, and you never develop cataract. So I don't know. I could not imagine where we ended up with the imaging that we have today that I did not have growing up with. It's outstanding. It's a synthesis of biomedical engineering, of biochemistry, and it will continue to astound.
Could you quickly touch on your opinion on the current state of technology to give vision to individuals that were born blind? I know you briefly mentioned the future of it, but where are we now?
So we are actually able to give gene therapy to at least some people with individual diseases. So that will continue. The hardest thing we have right now that we haven't overcome is the ability to give people vision if their photoreceptors are damaged completely. So people with submacular scars, we have a hard time overcoming that. The bionic eye, that's kind of, where people are looking at. And there are people who have had photoreceptor arrays implanted in the eye where they can get some gross vision out of that, but nothing like Steve Austin had in the $6 Million Man. There's a dated reference for you if you've ever had one. Actually, it was the bionic woman, I think, had the bionic. Who had the ear? Was it Steve Austin or
in the $6 Million? I think that was his name, right? I think it was.
Steve Austin had the eye, though. It was Janie had the ear. The bionic woman had the ear. So that's where we trying to miniaturize that. As that comes along, we may be able to hook up something that relays that will replace photoreceptors. There is a push toward whole eye implantation. That just boggles my mind. That's just ridiculous. Taking somebody else's eye and trying to align those fibers, that's an incredibly complex problem because there are over 1 million different retinal ganglions to interpret that appropriately. You have to line it up just perfectly. And so right now we're fighting, can you get a blood supply to the eye? They can do that. They can get a blood supply to a transplanted whole eye. The next problem is how do you keep it from rejecting? And then how do you get the ends of those fibers, those nerve cut axons to grow back appropriately? People are actually working on that. That just boggles my mind. So there's a lot that's happening in the future. Right now, though, it's very difficult if you've had damage to the photoreceptors to get useful vision out of an eye.
We'll do 2 more questions. Next up, what sort of experiences, possibly as a first-year physician, have stuck with you until today?
Internship. So I think, the one that sticks most with me was a patient that you're doing your best with, terminal disease, young person, just tragic, who we were just trying to keep functional, keep alive, keep cognizant, so they could sign their will the next day. And unfortunately, he had a stroke the night before when I was on call, and trying to ameliorate the damage, to try to prevent further damage, to keep him functional was very depressing. We did not have the tools at that time during my internship that we have now. We had heparin, and that was about it, and not the TPA that we have, the clot busters that we could use today for acute stroke. And that's always been a patient that has haunted me, that we were so close to getting him through to the next morning, where it would be easier for him to say goodbye and have his affairs in order. That's somebody that will always stick with me. And the flip side, the other part of my internship, I remember this 98-year-old woman who had no family, was demented, frail, looked at death's door every day I was there, and she coded. And the physician in charge did not believe in DNR, would never get a do not resuscitate order on anybody. He believed that everybody deserved maximum care. I don't know whether that was his belief or just he wanted to be able to charge for our services resuscitating. But to hear that crack of the ribs every time doing chest compressions as I ran the code was just devastating to me, to think that we are trying to save somebody with no quality of life at that point. And we're probably doing her more harm than good. So that's always been something that I think about. Unfortunately, as an ophthalmologist, I don't have to face that too often. Occasionally I will, once every 10 years, we'll have to have an end of life discussion with a patient. But one of the benefits of being a comprehensive ophthalmologist is that is not something I have to address very often.
So Preston, was this professional, but to some degree personal closeness with people who are now your patients, was that something that came natural for you when you were a kid? Or did you find with the passing of time that as you gained in professional expertise, that your ability to work with people in their many needs that they have, and the eyeball is the vision for the entire body, as you've been pointing out, did you find that you are able to develop a professional closeness with the passing of time? My question may not be a very good one, but.
No, it's one of the things about ophthalmology is it is a rapid profession. We see lots of patients, and we don't have a lot of time to spend with them. So you have to be able to establish a connection very rapidly. And I enjoyed both sides of ophthalmology. There's some diseases that are one hits and you're going to cure. You see that patient in the emergency room, going to take care of their corneal abrasion, they're going to get better. You may not ever see them again. There are other patients with macular degeneration or glaucoma you're going to see over and over and over. You're going to develop that bond with them over time. It's always easier for me to, when I was going to recommend surgery, see a cataract patient. I always like to do that over one or not just one visit, but a couple visits so that we can get that bond. I didn't want to be the person to say, yeah, I got cataract, we're going to take it out. Come follow me. You want to have that trust, that bond build up. So I liked that interaction with people, with most people. There's always a saying that medicine would be great if it weren't for the patients. Most of the time, it was a joy and a real privilege to take care of people, to trusted their eye care to you or their health with you. And I really looked at that as a privilege that when people came to me for care. There are tricks you learn, when you walk into a room and the 75-year-old woman is sitting in front of you, you don't say how old you are. You say, oh, how young are you? All right. You're looking in somebody's eye and you say, my gosh, how long have you been smoking? You can tell that from looking in my eye? And I don't tell them it's because I can see the pack of cigarettes in their pocket. So you learn a few tricks along the way that we all tend to do. And you think, I'm the first person to think of this. And we go to meetings, we find out we're all doing this. We all kind of came to this independently.
So what about the occasional person who declines to take your advice, especially when you're giving, and I'll give you an example. I had a patient recently, came in, middle-aged person who had a STEMI, a heart attack that did not show ST elevation, and enzymes proved it. And the first thing I hear is that the patient is about to leave against medical advice. And so I go in and sit, and I had this intense thing. I really need you to trust me and to understand that I want to help you, and that it is important at times that the patient and the doctor develop a relationship where they trust each other. Ultimately, the patient still walked out the door, no matter what I did. How do you handle that?
You have to realize that it's the patient's choice. And you can try to advise them as much as possible. You tell them, if it were my eye, you warn them of consequences. We see this oftentimes in glaucoma, where people want to take medicine, and medicine is effective to a certain degree, but at some point you need to do surgery to help preserve vision. And you say surgery, people get very afraid. You're going to do what? You're going to cut out my eye? Even cataracts, people are very afraid. My mother, one-eyed, right? She developed a cataract, and we had to convince her that it was the right thing to do. But you start talking about, you're going to put a knife to my eye? Really? I'm not going to take that chance, even when you know that the consequence may be slowly progressive vision loss. And especially with some of the diseases we take care of in ophthalmology, where it may not be blinding tomorrow, but it's going to be blinding over the next year or two. And the longer you wait, the less vision you're going to have. You're not going to recover vision in glaucoma that's lost. We can treat it early enough, we can prevent vision loss. But everything comes with a small risk, and that risk benefit may be very small. The benefit may be great, the risk may be small, but the risk is not zero. So you never know. And I think it's the hubris of a surgeon to think that they're always right. In glaucoma, our goal oftentimes is slow the progression enough so that they always have vision as long as they're alive. We may not be able to slow it completely, but does it matter if they were going to go blind at 150? Probably not, if they're going to only survive to 90 or 100. If I can give them functional vision through that time, yeah, they can lose a little bit. If it's coming more rapidly, and they're not going to have that functional vision at 90 or 100. Yeah, I'm going to see if I can tell them this is what we can do now. Here's the benefits of what we may be able to do if you allow me to proceed.
So Preston, you've been talking for over an hour and we're thoroughly enjoying it. You can talk as long as you want. You want to get up and take a break for a second? Yeah, I see you got a drink there. So
I'm fine.
Okay. We are going to move into your second half. Absolutely no hurry. We're thoroughly enjoying this. Just take it away and let's hear some cases.
So these are very typical cases, what would come into a comprehensive ophthalmologist's office. The first case, a 65-year-old woman who presents with slowly progressive painless decrease in vision in the left eye over the past 6 months. She's having problems driving. She's having problems reading. She's got 20/20 vision in the right eye, but her left eye is now 20/50. And we look at her pupils and her pupils function perfectly. That's important. We talk about in ophthalmology the 8-point eye exam, where we're checking vision, we're checking visual fields, we're looking in the back of the eye. So we're either looking at something that's structurally, looking at the cornea, or we're asking the patient, can you see this? Can you see this? Well, that's great, but when you're asking the patient, what Gregory House say, his axiom was everybody lies. So sometimes, you'd like to have an objective finding. Well, for function in the eye, the pupils don't lie. That's the only part of the routine physical examination of the eye that's objectively measuring function. So when I see that the pupils are normal, I know that the optic nerve is normal, and I know that there's not a large retinal lesion back there. So something is blocking the pathway, most likely in this patient, getting vision, the light rays back from the outside back to the retina. So we look in the eye and, well, we see this. And the nice thing about a slit lamp biomicroscope is I can take the light and make it a fine slit. If you just take a broad beam, shine a pin light in this patient's eye, you're going to see a black pupil. You're not going to see anything, right? You can do that to yourself. Do it to the person who's sitting with you today. Take a look at their eyes. What do you see in the middle of their pupil? Black. You're not seeing a lens. You're not seeing anything. But I can take that fine beam, make it to a small slit, shine it through. So now I can look at the cornea, make sure that's nice and clear. I can look at the anterior chamber. That looks fantastic. The cortex of the lens is nice and clear. But look here. This older patient getting some yellowing of the lens, and that's called a cataract, a nuclear sclerotic cataract. And that can be very difficult to see unless you have a slit lamp biomicroscope. Now, sometimes it's very easy to see. You get somebody who has a white cataract. This person can't see squat. He can maybe see the hand move in front of their face. They can't even count fingers with this type of dense cataract. So this is pretty obvious. This is what you would see in third world countries. We see a lot of this, believe it or not, at Parkland. You see some of this in private practice. People wait so long for their vision to get bad. They're so afraid of surgery, they come in with vision like this. So cataract surgery is the most common cause of blindness worldwide. And the tragedy is it's curable. All right, we can take care of this. We can remove the cataract and restore vision. It's indicated when a cataract is present, when the cataract is the cause of decreased vision, and the cataract is interfering with their daily life. All right. So if you have someone with a cataract and they're happy, I tell you, it's hard to improve on the happy patient. All right. If they're not happy, I tell people, you don't have to be unhappy. We can take care of the cataract. Now, early on with nuclear sclerotic cataracts, people just get a little more nearsighted. So you can put them in glasses and they'll be able to function. Very safe, easy to do. But cataract surgery is one of the safest and most effective outpatient surgeries in all of medicine. That's the great thing about what we do. So again, anything that blocks the light rays going through the cornea, through the lens, through the vitreous cavity to hit the center of the vision is going to decrease vision. In this case, it's cataract. And think about the lens. It's held in place by these fine suspensory ligaments called zonules. These zonules insert on the basement membrane of the lens. The basement membrane is this 10 micrometer thick membrane surrounding the lens. And inside the lens are all these fibers like an onion. So what do? Well, in cataract surgery, we dilate the pupil, and then we're going to make an opening, circular opening in the anterior capsule, it's that basement membrane, and we're going to remove all the lens material and leave just this 10 micrometer thick membrane, which the zygote is attached to. And once we do that, we're going to then put a lens implant inside that 10 micrometer thick membrane, okay, and restore vision. And the story of the lens implantation is fantastic. It goes back to World War II, where Sir Harold Ridley was a flight surgeon with the RAF during World War II. And he noticed as the RAF pilots came back from their bombing runs over Germany, that the ACAC, the anti-aircraft fire that the Germans would fire up in the air, which shattered their canopies of their cockpits. And some of those shards of this material, it wasn't glass, it was actually more of a polymethyl methacrylate material, would get in their eyes. And he noticed that that material in the eyes didn't cause any inflammation. That was very interesting because most times you get something in your eye, it's going to cause inflammation. So that was pretty interesting. He followed it away in the back of his recesses of his memory and didn't think much of it. So he was doing cataract surgery years after the war in 1946, 1947. And at that point, you took the entire lens out. You left nothing in there, left of the lens. You took the entire lens out. And you put people in Coke bottle glasses. And if you remember Jack Benny or George Burns at the end of life, they had these huge, huge Coke bottle glasses. Awful, awful. So the medical student who was assisting him that day said, I see you taking the cataract out. What are you putting in? He goes, well, we don't put anything in. We put them in the glasses. Well, the medical student said, well, that doesn't seem right. To take something out, should you put something back in? And that was the start of him thinking about, well, yeah, we could actually make a lens. You know, that material that we had of those airplane canopies that didn't cause any inflammation in the eye, that seems like that'd be a good thing to make a lens out of. So he made the Ridley lens that some people had it for 40, 50 years after his original cataract surgeries. The problem, they were very heavy because he made a huge lens and they tended to sink in the eye. So he was ridiculed initially for his early cataract studies. And it wasn't until the 70s when the idea started propagated again, that maybe we should put something back in to replace the lens in the eye, that now that's commonplace. We almost always put a lens in the eye so that people can see well. The cornea has 2/3 of the refractive power of the eye. The lens has another third, the last third of refractive power. So if you don't replace the lens, you're stuck with Coke bottle glasses. Here, when we put a lens implant in the eye, people can see fantastic without glasses. So I'm going to show you a little cataract surgery. And I cut out a little bit. It's about, I think I cut it down a little bit. Surgeries in ophthalmology for cataract, 10, 12 minutes long, usually. We make an incision and we have to use both hands and both feet. So you have to be able to use everything. You have to be able to drive a stick if you're going to be an ophthalmologist. So you're going to find that when I'm operating in the eye, I'm going to have sometimes an instrument in my left hand and an instrument in my right hand. And I'm putting viscoelastic in the eye, this viscoelastic device. If you just operate without anything, you can imagine you've got fluid, this watery substance, the aqueous, it'll just come out of your incisions. So we actually put this jelly-like substance in the eye. I use two different types of jelly. One's hyaluronic acid, one's hyaluronic acid with some chondroitin sulfate in it. And then we take a keratome, and this blade really hasn't changed over 100, 150 years of ophthalmic surgery. So we take this blade and we make this beveled incision so that this incision will actually self-seal without the need for putting any suture into the cornea. So I'm making this self-sealing incision. We're going to enter the eye. The little mark on the blade is a 2 millimeter mark because this is a 2.4 millimeter wide keratome. It's gone about almost 2 millimeters into the eye. And now we're going to take basically a bent needle and I'm going to incise that anterior capsule, that 10 micrometer basement membrane that surrounds the lens. I'm going to incise it and I'm actually going to tear a perfectly circular opening into the lens. So this is the critical part. This is what makes modern cataract surgery possible. The ability to do phacoemulsification or removal of the cataract through a perfectly circular opening. That way, having a perfect circle right on the visual axis, based on the visual axis, will allow me to put a lens implant in there that's going to be nice and centered and stay right there. And this is like tearing wet tissue paper. This is, you can kind of simulate this if you want to try this by taking a grape and trying to peel the covering of a grape in a nice circular pattern. Because this is on a hill, right? The lens is like this. Every time you pull this, it wants to extend outward. So you have to know your physics to be able to direct the tear so you get a nice, perfect circle. And actually, the surgery I love using a little digital imaging device. So in my right ocular, I can overlay a 5 mm circle onto the cornea and see that in one of my oculars and be able to just follow that around. So I get a perfectly centered circular capsulorhexis every time. So we get this, and then we're going to remove that lens material. So again, the lens is, we have three parts of the lens. We have the central nucleus for the lens. We have the cortex, which is a little softer around it. And then we have the posterior and the anterior capsule. We're going to keep that capsule. So right now I'm going to inject some fluid to separate those into 3 layers. Separate the nucleus from the cortex with this little injection of fluid, and you can see it cleave the nucleus away from the cortex and go right underneath the capsule. So I can separate the cortex from that anterior capsule and the posterior capsule. And now we're going to take ultrasonic energy and remove the lens. And this is a typical divide and conquer technique. And this instrument is actually vibrating at 44,000 times a second. You can't see that, but it's ultrasonic power. This goes back to the late 60s, where Charlie Kellman had a grant to come up with small incision cataract surgery. Just think about it. We used to take the entire lens out back then, leave nothing. That takes a huge incision, 13 mm incision. So we want to get an incision that's 3 mm, small incision. So he had this grant. He was trying to figure out, what can I do? He tried rotors. That worked to take out the lens, but also took out the retina and the iris. He was trying everything. He was at the end of his grant money and the end of his time for his research, and he had no idea what's going on. So he went to the dentist, and the technician there started cleaning his teeth. He's going, "What are you cleaning my teeth with?" "Oh, this is a Cavitron. It's an ultrasonic instrument. It's so delicate, it knocks the tartar off of the tooth without harming the enamel." And that was his aha moment. And you can still, I went to the dentist the other day, still the same Cavitron was there. He developed the Kellman Cavitron, which is basically the forerunner of modern ultrasound, which is state of the art for cataract surgery nowadays. So we're actually using ultrasonic power to break this up, to groove these grooves into the lens. We're going to make this into 4 pieces of pie, because, as you know, it's easier to eat pieces of pie than it is to eat pie all at once. So here we're getting down. We're going to make my last groove. I'm going to take my second instrument. See, I've got both instruments in the eye, and I crack that. And then I'm going to take each piece of nucleus and bring it to the center, because I want to emulsify this in a safe place. So I'm going to bring it to the center with some vacuum, some aspiration, some suction. And then I'm going to increase my phaco and just eat it up. Boom, it's gone. And we're going to do that with every quadrant here. And what we're trying to do is save just that small membrane around the lens, around the cataract, the lens, so we can put our artificial lens into the eye. Now, said we had to be able to drive a stick. Not only do I have both hands on an instrument in the eye right now, but my right foot is running my phaco pedal. So I'm determining how much power, how much aspiration, how much vacuum I'm creating. My left foot is running the microscope. So I'm truly using both hands and both feet at the present time when I do the surgery. So you have to have a little bit of coordination to be able to do this. So now I've got the nucleus out. That's the hard part of the cataract, the dense part. I've got a little bit of cortex left. Well, I don't need any power to get that out, so I can just suck that out. So I have what's called an IA instrument, an irrigation aspiration instrument. All we're going to do now is suck that out with that little hole. We're going to suck that extra cortex out, so I have a completely clean capsule. If you left this in, it's going to opacify and turn white. So that's why you have to get all of that out to make sure that you have a nice, clear capsule. And you can see we're using the red reflex. As the light bounces off the retina, that's allowing us to see this tissue, which is pretty transparent. So to be able to see this, we're using the light bouncing off with this coaxial light. I'm filling up that potential space now where the lens used to be, filling up with some viscoelastic, making an opening. And now we're going to put our lens implant in. This is a foldable lens implant. It's related to that same material that Harold Ridley put in, that polymethyl methacrylate. This is a different acrylic type of material, but it's going to go into the eye folded. As it warms up to body temperature, it's going to unfold and it will stay unfolded for the rest of its life. So we're able to go through a very small incision. 2.2 is small. It's actually a 1.8 millimeter incision we can get these lenses through. So very, very small incisions that don't require any suturing anymore. Not like the old days when you had huge incision, had to do a lot of suturing. So you see the lens unfolding right now. The next thing I'm going to do is take my eye instrument and take out all that viscoelastic that we put in to open up that bag. We're going to take all that out. If you leave it in, it gets stuck in the trabecular meshwork and causes a pressure increase, causes some glaucoma transiently. So we like to avoid that. So we get all that out, and then voila, we're done. We self-seal that wound, and we have a beautiful looking eye that sees 20/20 the next day. So that's the wonder of cataract surgery, bread and butter for ophthalmology. We go to case number 2. Here's a 25-year-old man, a young person, presents with sudden painless onset of decreased vision in the left eye. He's had type 1 diabetes mellitus for 10 years, so he doesn't see great in the right eye. He's 20/40, but he can't see squat in the left eye. He's count fingers. He can see, tell you he sees 2 fingers or 5 fingers, but he can't read anything. That eye is not very good. And again, his pupils work just fine. So it's not the optic nerve. It's probably not a large retinal detachment or a big retinal lesion, but something's blocking the light from getting in there. Well, in diabetes, you get these fine prearteriolar capillary occlusions. I say that right, pre-capillary arteriolar occlusion is what I meant to say. So you're actually getting small little micro infarcts, usually in the periphery of the retina initially. And it marches in closer to the retina. And here's a cotton wool patch. What that is a microinfarct of the retinal nerve fiber layer. What happens when you have dying retina? Number 1, it doesn't work, so it doesn't see very well. Number 2, it produces a factor called vascular endothelial growth factor, or VEGF. That happens if you cut yourself. This VEGF causes new blood vessels to grow. Those new blood vessels, great if you cut yourself on your hand, because it's going to get to the scar and make it vascular and get some healing going. In the eye, it causes these abnormal blood vessels to grow inside the eye. They don't stay in the retina, they grow into the middle of the eye. And they're friable, they're not normal. They bleed very easily. And if they happen to bleed, like this collection of neovascularization of the disc, and they bleed, you then get this. You get an eye filled with blood that you can't see through. You can see how fuzzy it is. This eye is just bled. It's got lots of blood blocking light from getting back to the retina to be able for this patient to see. Diabetic retinopathy is the most common cause of blindness in working age adults in the United States. And it's due to that retinal ischemia with production of VEGF from dying retina. So how do we treat that? Well, dying retina causes production of VEGF, dead retina doesn't. So we can actually use a laser, convert dying retina to dead retina, so we can stop the production of VEGF and get those blood vessels to involute. If it gets worse, you may actually have tractional detachments of the retina. So with repeated bleeding, you can get bands that actually pull the retina off the back of the eye wall. And you may need to go to pars plana vitrectomy, this special procedure we'll show in just a second, to improve the vision there. So again, PRP, pan-retinal photocoagulation, it appeals to my inner geek, right? I grew up a big fan of Star Trek, still am. Love the new Discovery series, been watching Picard, I even watched the Nickelodeon Star Trek Prodigy series that's out there now. So I like the idea. I've got my own little phaser, except it's attached to the slit lamp by a microscope, and I can go in and I can destroy all that dying retina, convert it to dead retina, and help preserve the vision in the central vision. Again, this is the center of your vision, the fovea, where most of your cones are that give you good color vision, give you good sharp vision. So you're sacrificing some peripheral vision, but that's already dead anyway from the diabetic damage.
Hey, Preston, point out the hemorrhages that are on the retina there.
So you can see here these little blot hemorrhages right here, all throughout this retina. All right, these are all laser scars out here from firing the laser. But you can see these little blot hemorrhages. You can see these abnormal these little neovascularization of the disc here. They shouldn't be there. Here's another cotton wool patch, this microinfarct of the retina, very characteristic of diabetes. There's just hemorrhages all over the place here. Now, the other thing you can do, because I said this was due to VEGF, we now have medicines we can inject. We can inject anti-VEGF medications into the eye. These are medicines created to treat cancer, but they also treat this proliferative diabetic retinopathy. So it makes those blood vessels go away. The disadvantage is you have to come back repeatedly for those injections. It may take 5, 7, 12 injections before we can make those blood vessels go completely away where you don't need injections anymore. Whereas if you do laser, once I kill the retina there, it's dead. It's not coming back.
So Preston, when you walk up to a guy with a needle to stick a needle in his eyeball for the first time, is he a little nervous?
They're very nervous. They're very nervous. It amazingly does not hurt like you would think. We have some tricks so we can numb the eye where we inject it, and these people do very well. We get people who have had 25, 30, 50 injections, and I'll show you how that works in just a second. But I want to show you here vitrectomy surgery. This is what our retina surgeons do. They can take an eye and look in the back. They dilate the pupil. They have to put an infusion cannula into the eye so that you're pumping in fluid. Otherwise, that eye is just going to shrink up if you don't replace what you're cutting out. You have 2 trocars here. One, you're going to put a light pipe in so you can actually illuminate see what you're doing. And then the other one is your vitrector, your cutting instrument. You're going to take away all of that abnormal tissue. So I'm going to stop here. I'm going to switch over to a different video. Let's see if I can find it. Had them all up a minute ago. Let's try this one. So let's just show this. So this is a patient not with hemorrhage, but it actually has bad floaters. And this is sometimes as people get older, the fibers will coalesce inside the eye and cause floaters, and they'll come out. So this is the light pipe over here, shining the light, and here's this vitrector. It's a cutting instrument. It's rotating around about 8,000 times per minute or more, making 8,000 cuts per minute or more to cut this out. And you're just getting rid of, at this point, of all this vitreous floaters. Same thing, if this was an eye filled with blood, it would look similar to this, where you're just cutting this out in the back of the eye and be able to clear up the pathway so that the light can go to the back of the eye. This is fine microsurgery. The retina guys, it takes an additional 2 years of training after ophthalmology residency to be able to do this kind of work. So let me go back to my presentation here in just a second and get rid of that. Well, let's get rid of that. Now we don't want to talk about EKG. Let's see. So going back to my share.
Oh, I'll tell you all about EKGs. You want to talk about
I know you would. Well, I will say I still have my
your Dale Dubin book?
I still have it.
The orange book?
That's somewhere. All right. So trying to see if I can get back to, I want this. Let's try that. All right. Y'all see it again, right?
Yes, sir.
Okay.
Yes.
So we'll go.
We actually see presenter mode.
All right. So let's get out of that. So I think I've got to go back to. So I found better stuff here. Okay, let's move down to case 3. All right. So share again. All right. Now we're back, right?
Yep.
Looking good. All right. Case 3. 75-year-old woman presents with sudden painless vision loss in her right eye. She's had cataract surgery already. She has a family history of macular degeneration in her father's side. Hint, hint, hint. She can't see out of her right eye. She doesn't see that great in her left eye. So you kind of know where I'm going with this. Look at the age. It's painless vision loss. This is what a normal eye looks like. You've got the normal optic disc. You've got the center of vision, the fovea here. It has the greatest concentration of cones. That's where your sharp 20/20 vision is. Your color vision is all centered around here. You get out the periphery, there's more rods. It's more your peripheral vision. You can see motion better on the sides of your eye. But nowadays,
Preston, is it true that our peripheral vision is black and white? I have
Yes.
read that. Is that so?
yes, you have more cones out in the periphery, which subserves your black and white vision, and you're able to detect motion better a little bit in the periphery as well. That's why you see things zooming, you'll turn your head and then track it with your central vision. We now have optical coherence tomography. This was not around when I was training, where I can actually see each layer of the retina in great detail. You can see the choroid, you see the basement membrane, you can see the junction of the inner and the outer photoreceptor layers, retinal ganglion cell layer. You can see all of this detail that we never could before. This is a nice normal fovea. This is the center of the vision where you have this little dip centrally in the center of the vision. Well, this lady has age-related dry macular degeneration, or AMD. You can see these drusen right here, these little bumps, which are lipofuscin. You think of it as waste deposits from the retina. These will accumulate over time, and over these little drusen areas, you'll get loss of photoreceptors, and that can coalesce. So we see this person with slow vision loss, maybe 20/40, 20/30 at this point. But we can treat this patient. And you can see on the OCT here, these little drusenoid, little drus all over the place underneath the retina. So how do you treat this? Well, we treat it with vitamins, believe it or not. We know from the age-related eye disease study and subsequent age-related eye disease study too, that taking vitamins, vitamin C, vitamin E, no more than 400 international units, because then you start worrying about increased risk of heart attack and stroke. But using lutein, zeaxanthin, these antioxidants, with zinc, you'll cut the progression of vision loss from intermediate stage to advanced stage AMD by 25%. Now, there's some thought that eating a Mediterranean diet or paleo diet will also help prevent age-related macular degeneration. I'm too wedded to my hamburgers, so that's not going to cut it for me. And then here's the problem. It can advance to this dry geographic atrophy of the retinal pigment epithelium, where you can see on the OCT, there's loss of photoreceptors. This is the photoreceptor layer. It's gone here. It's gone here. And it coalesces to this just loss of photoreceptors. Now, this patient can only see 2,400, count fingers. That's what we're trying to prevent. Now, sometimes you'll get abnormal blood vessels growing up through these drusen, or through those areas of drusen. That causes wet age-related macular degeneration. Again, these blood vessels are abnormal and they'll bleed, and that causes a scar in the back of the eye. So we want to prevent that. How do we treat that? Well, again, before we had either no treatment, you just got a scar, that's it, tough luck. Or like my mom, you got laser, and you hope that the neovascular membrane was a little bit off the center so that you could still have some vision after treatment. Now we actually inject anti-VEGF agents into the eye, where we'll go and put in bevacizumab or aflibercept. These are medications, again, their anti-angiogenic properties were first developed to treat cancer, but they cause regression of these abnormal blood vessels, and people for the first time actually see better. May not see perfect, but for the first time, we can actually tell people there's a great chance we can make you see better than when you came in with wet AMD. So this is what this looks like. You know, it looks pretty brutal. We're going to stick a needle in your eye. Don't move. but we were able to numb up the surface of the eye. And once you get through the sclera doesn't have really any pain fibers in it. It's not too bad. You squirt that medicine in, you get a little sensation of fullness. And then we check to make sure that the pressure comes back down to normal quickly, that you're still able to see well, and we send you home. The problem is it may take multiple injections to make these blood vessels go away. We haven't stopped the underlying process. We have stopped it transiently, and hopefully some cases we can do this for a dozen injections and not need any more. Some people need continued perpetual injections, and that's the real problem we have. We're looking at new drug delivery systems where we can put in a depot, refillable reservoir into the eye so that we can just fill it up once a year and have a slow release of anti-VEGF medication in there. So we'll see what happens in the future. So here's the next case. 25-year-old man complains of blurred vision at distance without glasses. Maybe some of you out here, maybe this man. Uncorrected visual acuity of 2400 in both eyes, but you put him in glasses with -3 diopter sphere, you're 20/15. Rest of the exam, perfectly normal. This is simple nearsightedness, no problem. So how do you treat that? Again, glasses are the safest, most reliable way to correct refractive errors. Everybody, you know what this is, this picture of what that is? These are lentils, all right?
Okay.
And somebody noticed that lentils looks like the lens of the eye. That's how we got the word lens for eye, the lens in our eye or lens in our glasses. So again, glasses is the safest, most reliable way to correct refractive errors. I love glasses because again, it protects me from somebody throwing a punch in my eye or spitting at me or whatever. You don't have that with contact lenses. Contact lenses, again, first thought up by Da Vinci back in 1508. But we weren't meant to have a piece of plastic on our eye. So you're decreasing the amount of oxygen that gets to the cornea, and that can cause problems down the road. So you have to be absolutely perfect. I had a one-strike policy with my patients. You had one strike. If you messed up once, then my answer was, you're not diligent enough to wear contact lenses. You have to be diligent. Otherwise, you're going to end up with a corneal ulcer or bad vision loss from your infection. Or you can do keratofractive surgery, LASIK or LASEK or PRK, photorefractive keratectomy. This comes from the use of the excimer laser, which was back in the 1970s used to etch IBM silicone chips. It's a cold laser, it doesn't create heat, so it's safer to use on these delicate tissues of the eye. It was first used in human eyes in 1985. So this is what LASIK or laser-assisted in situ keratomileusis is. We're going to raise a flap. In the old days, we actually use a microkeratome, a blade, to create that flap, and then treat and flatten the retina underneath that flap, then put the flap back over. You can actually do this without raising a flap. That's called photorefractive keratectomy. Problem with that is it hurts like heck. It's basically causing a corneal abrasion. Whereas if you do LASIK, by putting that flap back on, you don't feel the pain. One of our administrators in our department was in the pilot study for hyperopic photorefractive keratectomy, and she had a wonderful result. And people would ask her, well, how did it work? Oh, I see so much better after having this. But again, that was done without a flap. So they'd ask her, well, did it hurt? And she said, it was like having childbirth through my eye. So LASIK takes away that pain. So I'm going to play this little video for you here, maybe.
LASIK surgery begins with you entering the laser room and lying down in a relaxed position on the procedure bed. Next, anesthetic drops are applied to numb your eye. The surgeon will then position you properly under the laser machine. A painless lid separating device will keep you from having to worry about blinking or closing your eye during the procedure. Next, your doctor will use an advanced automated device to create a thin flap of tissue on the cornea, the clear front window of the eye. Your doctor will then gently lift this flap and hinge it back out of the way. You'll be asked to fixate on a blinking, fuzzy red light, and your doctor will precisely align the laser beam with your eye. When everything is just right, your doctor will activate the laser. Painlessly, computer-controlled laser light pulses will remove microscopic amounts of tissue, gently reshaping the cornea. The pattern of laser treatment is determined by a sophisticated program and based on the detailed measurements that were taken during your preoperative examination. Before you know it, your procedure is over, and the surgeon will gently reposition the flap, smooth it with a special medical sponge, and allow it to dry for a short time.
So one of the blessings of my life is I never did LASIK in my practice, or radiokeratotomy, or some of these other refractive procedures. You're taking eyes that are 20/20 with glasses. And in my mind, you're trying to get them out of glasses. Well, that may be a laudable goal, but the other possibility is you can make them worse. So you can see I wear glasses. Most ophthalmologists wear glasses. We're not willing to take a risk with our eyes. Some people do. Some ophthalmologists have had LASIK surgery and done exceptionally well. It's gotten better and better over the years. But having said that, I still think glasses is the safest, most reliable way. I like doing cataract surgery. People with cataracts come in with poor vision, and I can make them better. The best I can do with LASIK is give you the same vision, just without glasses. So in the old days, we used a mechanical microkeratome to make that cut. Nowadays, we use a femtosecond laser to make that cut, so it's a little easier. I'm going to skip the video of real LASIK surgery. You really can't see the actual beam doing anything, vaporizing that tissue. The last case I want to talk about, 70-year-old woman with blurred vision, had a recent motor vehicle accident while backing out from a parking space. It's fallen over twice over the past few weeks. Visual acuity is still 20/20 in the right eye, but 20/30 in the left eye. Not bad, not horrible, but the pressures in the eye are high. And I can tell you a normal pressure in the eye is under 22 millimeters of mercury, and hers are 28 millimeters and 30 millimeters of mercury in her eye. So we measure pressures by using an applanation tonometer. This is attached to our slit lamp arm. It actually touches the eye, and we know that if we applanate this prism, applanate the cornea flat at 3.06 millimeters diameter, the force in dynes to make it flat to that diameter times 10 is the millimeters of mercury inside the eye. So we can measure pressure, and usually if you look at the optic nerve, there's a little cup in the middle of this disc, this little depression of the optic nerve. Now, normally the ratio of the cup to the disc is less than 50% or less than 0.5. We say the cup to disc ratio is 0.5 or less. In glaucoma, you get damage to that cup. You get elongation of the cup vertically, you get deepening of the cup, and you get loss of the neuroretinal rim. And that's, again, those are those axons of the retinal nerve ganglion cells going in to form the optic nerve. So the high pressure is pushing on that optic nerve at this very critical site, the lamina cribosa, as it exits the eye and causes damage that causes visual field damage. So here is what that person saw. The right eye, the 20/20 eye, this is the normal blind spot. Everybody has that. That's where the optic nerve exits the eye. But this person also has this paracentral scotoma. Very small. It's not in the center of the vision, so they may not notice it, but it's there. And we can pick it up on visual field testing. Where the left eye, 20/30, but you can see this person has lost almost the entire upper half of vision. That's very characteristic where glaucoma usually starts in the upper half of the vision. You don't notice it so much because we live our life down. You don't notice the loss of not being able to see the birds as much as you do not being able to read. And then inferiorly, you have this arcuate defect. So in glaucoma, the tragedy is you start getting a tunneling of the vision. You lose the vision from the periphery inward, and people may not notice it until it's too late. So when we talk about the fluid forming by the ciliary body, it percolates between the iris and the lens into the anterior chamber, and this is where the aqueous lives. This aqueous fluid keeps the eye pressurized. It exits the eye through the trabecular meshwork, goes through collector channels back into the venous system, where it goes back to the heart. So in primary open-angle glaucoma, this trabecular meshwork gets clogged with tissue as we get older, and the pressure goes up high and causes damage. I can show a little bit of a video here. So you can see the eye in cross-section. the fluid is made by the ciliary body, it goes to the aqueous, the anterior chamber, and it exits through this trabecular meshwork, the sieve that gets clogged up. We don't have a chemical rotor-rooter. That's what we really need to clean it up. We have to find other ways to decrease the pressure. High pressure pushes on the optic nerve as it exits the eye of the lamina corbosa and can cause damage. And slowly, people will lose that peripheral vision. And again, it's such a slow process, they may not be aware of it until it's too late. And that's the true tragedy of glaucoma. And we have medications that can decrease aqueous production to decrease pressure. We can increase outflow through uveoscleral mechanisms. There are laser surgeries we can do to get increased outflow through the trabecular meshwork. And there's other surgeries, trabeculectomy, aqueous shunt surgery, that we can do to form a new pathway for the fluid to get out of the eye. And again, now there's newer, more minimally invasive surgeries that we can use. I'm going to skip the video on this too, since we're running out of time. And I want to be cognizant of the time you have, because I know there are better things to do than listen to me. This is what we're talking about. We actually, in trabeculectomy surgery, make a guarded flap so that fluid can percolate through a guarded flap in the eye where it's underneath the conjunctiva, and the conjunctival vessels will absorb that extra fluid to decrease the fluid. This is kind of the gold standard for glaucoma surgery. And again, there are now much less invasive surgeries that we can do to decrease pressure in the eye. Right, I mean, I can talk about matching in ophthalmology, but a lot of this, well, some of it's actually worthwhile. So I'll briefly go through this.
Preston, let me give you one of the comments one of our students just said, sure. Which I agree with. He says, quote, this is Neum. I think the best thing we could be doing is listening to this talk. This is incredibly informative. You've got 330 kids hanging on here. You do whatever you want.
Okay.
This is a great talk, Preston.
Well, I'll talk a little bit about what I, as a program director, look for. First, what are our applicants looking for in an ophthalmology program? This is true from no matter what you do, whether it's ophthalmology, medicine, emergency medicine. You want a program to be able to prepare you for your future training in position, no matter what it is, whether you're going to be in a solo or group practice, in private or academic practice, you're going to be a comprehensive generalist or a specialist. You want a good esprit de corps, because again, you're going to spend 3-4 years at a program, maybe more. You want to have some fun. So you better enjoy the people you're with. That's why I enjoyed being here at my institution. People like Dr. Fowler, my residents, my co-faculty. That's why I enjoy being here. You want faculty who are available and who want to teach, and that's really important. You want a depth and breadth of faculty. In ophthalmology, again, we have 9 or 10 subspecialties. You want to be able to see what all those subspecialists do. You want to learn from the best. And you want a variety of patients and clinical resources. If all your patients are Caucasian, you're going to miss a whole different breadth of pathology. And if you have a mix of people coming to see you. At Parkland, we keep 142 languages on tap in our language line to be able to talk to our patients. People ask me, do you have a global ophthalmology rotation at your institution? I say, yes, it's called Parkland, because we have people coming from the third world coming to Parkland, to a urban county hospital for care. That's what you want to see, where you do not only state-of-the-art surgery, but I have also treated patients who had couching of their cataract by a witch doctor in Africa and had complications from them, be able to take care of those kind of complications. What am I looking for? Well, I know from your application, you're going to be intelligent, hardworking, and motivated to learn and scholarly. I hope you have the technical skill to be a good surgeon. So I'm hoping you've gone and looked under a microscope and used virtual reality to see what's going on. You definitely have to be a team player. You can't be Dr. House, all right? That's not allowed. It takes a healthcare team with the complexity of medicine today to be able to interact with not only your patients, but your staff and your peers and your colleagues and your other specialties to be able to care for the complexity of the disease we have. Research is becoming almost required. I don't like that, quite frankly. We use it as a tiebreaker if you have 2 equal period people. But not everybody's going to want to do research. I think you need to understand how to read the literature and understand the literature, but I'm not sure it's necessary. You have to do research. And it doesn't have to be an ophthalmologist. I'll talk about it in a minute.
Preston,
and absolutely,
Preston, any difference in DO and MD? Do you care?
there are biases out there. I think you have somebody, we have testing now. We can look at the cognitive ability of patients, people who train in DO and MDs. I think the greatest problem we have is MDs. We're got an implicit bias toward MDs, quite frankly. But there are some great DOs out there. I go to some DOs for some of my medical care and some subspecialist DOs as well, and they do an excellent job. So, once you get into the residency, I think everybody's trained the same way, whether you're DO or MD. I don't have a problem.
Yeah, 7 of our 22 emergency medicine incoming residents were DOs last year. So, we look at the person,
Yeah, absolutely. And there's a lot to be said for taking a whole body approach to disease.
No kidding.
One of the things we stress, and I try to stress, is we are physicians first, ophthalmologists second. And unfortunately, there's been several times where I've been on transatlantic flights, and they ask is there a doctor on board? And you get an ophthalmologist and an allergist immunologist trying to take care of this guy who is basically had too much Valium with his alcohol. Or is having shortness of breath, or is throwing up. And I'm going, really? You want an ophthalmologist? Out of all these people, there's not somebody better qualified. But you have to be able to treat people as a physician first. So when I fly, I have a little, article from the New England Journal of Medicine about flight medicine, and I have an app that helps direct me for flight medicine, because I'm not a Dr. Fowler. I've been a long time since I've run a code. And absolutely no jerks allowed. That is an absolute in medicine, quite frankly. And if you are, please go to
somewhere else.
Politics, I don't care. This is a great website. AO.org talks about ophthalmology. There's a section for medical students that talks about it. These are just matched statistics. We don't have a scramble in ophthalmology. There's only one unfilled position last year in our match. Most of our people who match are U.S. seniors. Again, the odds of matching pretty good, 74% overall. And if you're a U.S. senior, 80%. So 4 out of 5, that's not bad. And of those people, 32% of people who match got their very first choice, and 2/3 got one of their top 3 choices. So it's not as competitive as people may think, but it is competitive. You need to do well. It's an early match, so you have to register early. The problem we see is people apply to so many programs. There are about 140 programs in ophthalmology. And when I applied to 8 programs. And now the average number of programs people apply to are 79. And that leads me to a little bit of game theory. The prisoner's dilemma, if you're aware of this, if you have 2 criminals who commit a robbery, and both, they separate them, and the cop goes into criminal A and says, we'll get you a break. If you testify against your buddy, we'll make it go easier on you. We'll lay the bricks on him, make him go to the big house for a couple of years. Well, they both stay silent, don't tell on each other. They go to prison for 3 years. But if criminal A testifies against his buddy, he only goes to prison for a year. Criminal B goes to prison for 15 years. But they both rat each other out. They both go to prison for 10 years. This is similar to what we see with the application process. If people would just be a little more selective, we would have a better chance of getting the very best people into the programs they want to go to. But we find that, if one person says, well, I'm only going to apply to 10 programs, the other guy says, I'm going to apply to 80 programs, guess what? Who has the advantage? The guy who applies all over the place. So now we get basically this problem here where everybody's applying everywhere. We don't know if you're really interested in coming to Dallas or not. Maybe you want to only see California, but you're going to apply everywhere just to be safe. And we end up, applying, interviewing people who may not want to come here, or may have a specific location, or worse yet, some programs, because they don't know who to apply. They think, well, I'm not that good a program. I can't look for the very best. So I'm going to just to interview some people who aren't really good, because I know they'll come here no matter what. The whole purpose of the match is to get the very best people into ophthalmology. That's what we want. So right now we're all struggling with this overload of applications. And I just went through this past match, 698 applications for our 9 spots. That's pretty much the entire pool applied to my program.
We had
And we know that-
we had 1,800 applicants for 26 spots this year. And Dan Septum, family medicine, said they had 2,000 for 12 spots.
It's
Unbelievable.
nuts. It's truly nuts. And the problem is, if I have 300 applications, I can read every one start to finish and give a really good holistic review. When I've got 700 applications, that's a lot tougher to really spend the time to get to know each application and give it the time it deserves. And there's not a real, once you get toward this past year, you kind of see this break at 62. But if you look at past years, really at 40, more than 40 applications of ophthalmology, you're either a good applicant or you're not. If you get everybody did 40, that would have no effect on each individual's chance of matching, quite frankly. And we know that if you have 6 interviews, you have an 80% chance of matching, 96% chance if you have 11 interviews. So what are we looking for? How do we make our decisions? Well, quality of medical school is important. Not quite as important as it used to be. A brand new article out this month looked at the top 20 programs in ophthalmology and found that we're more willing to look past the quality of medical school and look at the individual and say, here's somebody who's really outstanding at, a school that may not be recognized as a real top research medical school. So that's not quite as important. Class rank is important if you have a class rank. We're going more and more now for pass-fail schools. That's very hard. We're looking for some way to look at cognitive score. How do you compare knowledge base compared to somebody else? Well, we used to do it with the STEP score. We only have 1 more year, but the STEP 1 will be not pass-fail. We'll actually have a score. In 2 years, it's going to go to pass-fail, which means that how do we rank people, cognitively if they have no STEP score, they have no class rank. Most medical schools, Southwestern included, doesn't have grades for the first 2 years for the basic science. They only have grades during the core. So that makes it tougher. So it's going to be interesting to see if we go back to more quality of medical school when we lose some of these tests that we're able to do. And I've even heard, for example, anesthesia programs now saying, we're not even going to look at you unless you take step 2. We're preparing for the loss of step 1. And you can see step 1 scores have been going up, because medical schools have recognized the importance of that step score. So they're giving you time off. You're going to have 6 weeks to study for a step. That's ridiculous. I mean, I'm sorry. That's tells me that if you give enough time, you can learn something. That's not how you're going to learn for the rest of your life. You have to learn on the fly. You have to do practice-based learning and improvement throughout the rest of your career. But yeah, step scores, high step score, you're more likely going to match. I bet it's going to be the same thing for step 2 scores now in the future. So what do we look for? Well, we look for honors and awards. AOA, if you're in the National Medical Honor Society, Alpha Omega Alpha, tells me you're in the top quarter of the class. That says a lot. I don't have to worry about your cognitive development. You've shown that you're way up there. Gold Humanism is a peer voted society where your peers actually say, this is a guy I think is great. That means a lot. When it tells me a lot about your team ability, the ability to work with others. We look for your community service and your work experience. I love seeing somebody who has what my associate program director says has done a Joe job, right? Has worked, in retail, has worked slinging hash, done more than just doing research. Because I like seeing somebody who's had to get up at a specific time and put an I-9 in and go to work 9 to 5 and come back and do something. So I liked those kind of experiences as well as research. And again, research it shows interest in ophthalmology. Only 54% of published papers and people who applied to ophthalmology are actually ophthalmology related. My research was during college. It was in electrical engineering on the Texas Reconfigurable Array Computer Project. Nothing to do with medicine. So research, it really doesn't get you into a better residency. To me, it shows interest. Yeah, if you're a PhD, that brings something different to the program. I'm going to look at you a little harder than I would somebody who doesn't have a PhD. Those are pretty rare. Again, don't spend all of your fourth year medical school doing ophthalmology rotations. We want you to get a broad medical background that's going to help you more than doing ophthalmology. You're going to write an autobiographical sketch. I want to know about you. What brought you? Just like you asked me, what brought you to medicine and ophthalmology? I want to know the same about you. Why do you want to do ophthalmology? What brought you to this field? Tell me about yourself. And then there's focus questions now that you can, different prompts you can answer. And we look at transcripts. I go back to college because medical school transcripts aren't very revealing anymore. There's such high grade inflation. There are medical schools out there where 80% get honors on every rotation. Well, that doesn't help me. So I go back and look at your college transcript. Did you spend the first semester of college, drinking beer and partying, getting all D's and F's before you wised up? Did you get into medical school and then just forget to do the last half of your senior year and decide to party? I want to know about you and see what's going on and how quick does it take for you to adapt to a new climate. And then you're going to get letters of reference. And unfortunately, these are truly letters of recommendation, not of evaluation. So that's what the dean's letter is supposed to be. It's limited help from some schools. So you want people who are really going to write you a tremendous letter. It doesn't hurt, just like you're interviewing for medical school. Ask somebody, can you write me a great, excellent letter of recommendation? They say, well, no, that's okay. I'll find somebody else. You don't want to take a chance. You want somebody who's going to sit there and say, oh yeah, man, I'll write you a letter. I'll make you look so good. You'll be up for sainthood. That's the kind of answer you want. If you're somebody who is from an underrepresented class in medicine, all right, then we're looking at that more and more because we want more diversity in our classes, both in ophthalmology and in medical school. And again, the dean's letter for ophthalmology, they usually arrive after I made a call whether I'm an interview or not. So I'm reading the dean's letter when I'm interviewing you. That can be very informative. But again, some of these dean's letters are just incredibly stupid. My favorite graph of the dean's letter is the number of people in each quartile of the class. And there'll be a bar graph, 25, 25, 25, 25, as if I need to be taught what a quartile is. Yes, it's 25% of the class. Yeah, that sounds about right. I first saw that at the Texas A&M dean's letters. They don't do that anymore, but other people have done that instead for them. And it's just an incredibly waste of space and paper. And then again, it used to be that some people would put out cattle calls. It was first come, first serve. So when it's interview time, you're checking your email, you're getting those alerts immediately because in the old days, you weren't fast enough to respond and you'd say, you were told, oh, I'm sorry, we already filled up our interview. That's wrong, quite frankly. Basically, I want to send out an invitation to people I really want to talk to. So I'm going to keep a spot until I'm told you can't come. Our matches basically stop that, which I think is great. So there's no cattle calls anymore. We ask people and then that spot's held for a certain amount of time for you to be able to have some time to respond. A day, 2, 3 days, not hour. In 2021, all our interviews were virtual for the first time because of the pandemic. It was interesting. We ended up having to put a lot of our information on our website very quickly. We were ahead of the curve, I think, compared to other programs with that, and it really helped us. We had our very best match ever. But I still like seeing people face to face in my office. Number one, when you're doing a virtual interview, you're in your own environment and you're very comfortable. And I'd rather you be in my environment where you're not quite as comfortable. And I want you to be able to see my program. You're going to spend 4 years in a position in a town. I think it's important that you spend some time and figure out what that looks like. So this year, the match was going to have an open house available, not so you had to go to an open house. It was actually made so that the programs could have open houses after we submitted our rank lists. And that way the people could decide which programs they wanted to look at and take a second look at before they submitted their rank list. The only problem is Omicron. So we basically said, it's stupid to have people fly in from all over the country, expose themselves to the Omicron virus on the plane, come to Dallas, expose my residents and myself and our faculty to Omicron virus. So we did not have an open house. I think most of the programs followed our lead. But it's a different environment with virtual, and I hope that goes away. I don't think it will. I think the future of interviewing for all programs is going to be virtual, because again, it cuts down the amount of money that you have to spend to travel everywhere. But the flip side is then you don't get to see what that program is really like. And so this is the match count we had this year. Again, we didn't start interviewing until November 1st. Our rank is going to be February 8th. So next week, we're going to find out our new internship class. And again, the only other thing I'll say is there are 3 internships out there in ophthalmology right now. I prefer the integrated internship. That means you're an ophthalmology intern from day one. I control what you get to do, which means that I can just say to my medicine colleagues, I want them to do rheumatology and endocrinology. I want to do these subspecialty electives. The joint preliminary internship basically means that you're not ophthalmology intern day one, you're a medicine intern or a surgery intern. You get to do 3 months of ophthalmology, but those other folks control your destiny. So they can do whatever they want. They can make you a scut puppy for 9 months, and then you get to do some ophthalmology. And then there's an additional separate year that means that some programs just couldn't get together to do either of those possibilities. They have a grace period until next year. So this year, those people who don't match into a program with the upper 2 will have to do the 2 matches, not only the SF match for ophthalmology, but they'll have to do a separate internship match. And the whole point, again, of interviewing the application is getting that interview. If you can get the interview, then you can make your case of why you need to be an ophthalmologist. So with that, 99 slides later, I'll stop.
That was marvelous, just marvelous, Preston. The questions that are pouring in. So do you think that there may be a virtual component, forgetting Omicron for the moment, indefinitely? What do you think?
Yes, I do. The cost of medical school is outlandish anyway. People on average are leaving medical school if they have debt with just under $200,000 worth of debt. And then on top of that, to ask people to fly to 10, 11 interviews.
And 10 or 15,000 additional dollars doing interviews.
Exactly. So it makes sense to do virtual interviews for the applicants. The downside is you don't get that feel of what that program is like. You need to be able to see where you're going to live. I think that's extremely important. You wouldn't take a job sight unseen and say, oh, I'm going to sign up for 4 years and I'm going to live in Podunk, Illinois. No, you're going to want to see Podunk, Illinois. I guess the only people who do that, if you join the military, you're going to go wherever they tell you. But most people will.
Are you more likely to accept a candidate who's actually done a rotation with you? I mean, they've actually come, as opposed to you interviewed them, and let's say they did well in the rotation.
So that's the key. That's the key. So number one, doing an audition rotation with me does not guarantee an interview. I'm going to interview you based upon your application, period. All right. Now, if your application is great, yeah, I'll interview you. And then that audition rotation may help you or it may sink you. Because again, you can hurt yourself just as much as you can help yourself on an audition rotation. So if you're going to do a rotation, make sure you do everything right. And you don't know who's going to be the person, resident, the staff member, who's going to say, hey, this guy mistreated me, or he was rude to me, or this person went out of his way to help me. He was fantastic. You have to be very careful if you're doing audition rotation. I think for people who aren't in the top half of the class or transcripts don't look quite as good, yeah, audition rotations would be important to help maximize your chance. There's still program directors out there who do want to know, they'll take the devil they know rather than the devil they don't. We are fortunate here, we have such a good reputation. I don't have to play that game. I like audition rotation for visiting medical students because they get to see me and they get to go back to their institution and say, hey, I just saw this fantastic program. And that gets transmitted to the rest of their applicants and down the years for their faculty to say, you know what, I've heard great things about UT Southwestern. Well, you might want to think about looking at them.
And so, Preston, how important is the interview for you? I know that, you know, we had 1,800 applicants. We interviewed 240 for 22 spots, 10 times as many as we plan to accept. And I'll tell you, they could have, you know, fairly average board scores and decent grades. But if their interview was great, as opposed to great board scores and grades, but their interview stunk, you know, we have what we call the 3 a.m. test. You know, what are they going to be like at 3 a.m. in the ER when you've got a full house of patients? Are they going to be hardworking and pleasant? Or are they going to be jerks, like you said?
The interview is very important. It's very important. So you need to, very important. Because again, for our program, we have a selection committee. And I've learned over the years, once you get that interview, all bets are off. I tend to, since I've lived with all those applications and know them by heart, I factor in that application a lot, as well as the interview. A lot of the colleagues on the selection committee, some of them, that's that interview. They want to get that feel of you. We ask the residents what they think about you. So there's a social event the night before. And so we want to know, how do you interact with the residents? How do you interact? Were you the person who stood away from everybody else and didn't interact with anybody? Or were you the person who was making fun of your fellow applicants? Maybe you want that person. So we look at everything. So yeah, getting the interview is very important. But I've also seen our own medical students that I know very well who just get flat out nervous and blow the interview. And since we know them, we're able to give them a little bit of a break. But still, what about the people I don't know very well who blow the interview? So that was me applying for medical school, quite frankly. My wife was a year ahead of me. She skipped her senior year of college and got into a different medical school in Houston. And I went down there thinking, this is the gal I think I'm going to marry one of these days. I really want to go to this medical school down there. And she had told me about one of the interviews there, an anatomy professor who was a very well-known instructor at the school who had some very interesting characteristics. And I can tell you, I must have used the term per se about 5 times during my interview. Well, per se, well, I think the answer to that per se, I knew, walked out and said, I blew it, and got waitlisted at that institution. And when Southwestern came to me and said, we want you, and we're going to give you a scholarship, I said, I'll go to Southwestern. They want me. So it's easy to blow something. But it's not the end of the world. So
Preston, God bless you. We're so grateful. You got enough energy for a couple of questions?
Sure.
Aditya, pick a couple or 3, and let's be kind to our guest. He's had a long day. That's why he's wearing scrubs. Aditya, take it away.
Yes, sir. So first off, how much time do you spend on procedures in a normal week? How many procedures do you do, and how long does each of these procedures take?
So as a comprehensive ophthalmologist, my main emphasis is in cataract surgery, cataract and refractive surgery. The procedures themselves take 10, 15 minutes, may go a little longer, especially if I'm teaching with residents, it'll take a little longer since they are new beginning surgeons. I'll spend, like I said, about a day of my time in the OR. I spend another day currently in administration, and then the other 3 days I'm in clinic, either in my own clinic or I'm staffing residents in their clinics.
Okay. And one final question, just to debunk any conflicting arguments people may have on this. With COVID moving more things online each and every day, do you think screens and technology have harmed people's vision as they progress in life?
Well, actually, there's been data, especially out of Asia, looking at the increase of myopia due to increased screen use. And we know that even before the COVID pandemic, there is an epidemic of nearsightedness in Asia, and especially in East Asia. And just adding more sunlight exposure, getting kids out onto the playground 30 minutes, 40 minutes a day more will decrease the incidence of nearsightedness. Now we're all inside. We're afraid to go out, to play with others, and parents are keeping their kids away from play groups. And so, it's going to increase the risk of nearsightedness. So again, that means you have to wear glasses, but there's more to that. The longer the axial length of the eye, there's a greater chance of retinal detachment and other serious problems down the road, myopic degeneration with cortical neovascular membrane and vision loss. So it is a true epidemic right now. So get off those screens, do something outside, go for walks. It's an issue.
Do the LCD screens of laptops cause cataracts?
No.
Thank God. All right, Preston, thank you so much. Aditya, Preston, can we do the next slide, please?
Yes.
And we're putting the links up. There we go. Aditya, you want to take it away?
Yes, sir. Here we have the quiz link for tonight's session, as well as in the chat, I'm posting the link to the quiz as well as the past session 11 quiz on pediatric emergency medicine. So you can take your time, watch that session, and then complete that quiz as well to earn an additional couple hours of virtual shadowing. For those of you that have taken the time to attend and participate in the chat, thank you all. For Dr. Bloomquist, thank you so much for taking the time this evening. It was truly an inspirational.
Yeah, and Preston, thank you so much. Let's ask everybody to put thank you, Dr. Bloomquist, into chat. So Preston, take a look at chat so you see 300 people barreling their thanks in there. Thank you so much, Preston. What a wonderful talk. It was so
well, thank you very much.
And heartfelt.
It's my pleasure.
Typically, we will post this talk on YouTube for the virtual shadowing website. And typically about 5,000 students will watch it, pre-healthcare students. Each one of them will probably see 100,000 patients in a career. 5,000 times 100,000 is 500 million. Tonight, Preston, you've touched 500 million lives through this wonderful discussion, and we are so deeply grateful. So to all of you that are still with us, we want to thank you for coming. On behalf of Dr. Bloomquist and the whole virtual shadowing team, we want to thank you for coming, and we wish you a good evening. And